Hi, welcome back to Revise Smart. I am Dr. Rahul Vijayan. Today we are going to discuss a new topic, that is Fabry's disease. So let's get into the topic. So let's understand Fabry's disease. Fabry's disease is a X-linked lysosomal storage disorder. It is caused by deficiency or complete absence of an enzyme called alpha galactosidase A, also known as AGAL-A. This is due to the mutation in the gene in X chromosome. Why it is important? So it is predominantly occurs in a male child. It is characterized by a enzyme deficiency, that is alpha galactosidase A, leads to substance buildup, that is GB3, globotriaoside ceramide. This enzyme is necessary to break this GB3, which is a fatty substance. If there is an enzyme deficiency in lysosome, this GB3 will accumulate. So this progressive accumulation leads to tissue damage. This is the basis of Fabry's disease. Or what are the target tissues in which Fabry's disease is going to affect is mainly kidney, especially podocyte as well as glomerular, which lead to end stage, that is CKD, and heart, that is cardiac myocytes, later can form fibrosis, blood vessels, that's where our rheumatologist will come to play, that is it can present as small vessel vasculopathy causing ischemia and stroke, and also nervous system. These are the tissues: kidney, heart, blood vessel and nervous system, where Fabry's disease is going to affect. Coming to the incidence, traditionally we thought that Fabry's is a rare disease, that is it is approximate 1 in 40,000 or to up to 70,000 incidents. But in the later studies, it is found out that it is more frequent, that is 1 is to 3,000 or 1 is to 10,000 recently, according to the Japanese cohort, of which it is more predominant in the late onset subtypes rather than the classical subtype. So in case of Fabry's disease, there is two phenotypic spectra. One is classical Fabry's disease, which typically presents with the onset in childhood and adolescence. This form is often severe and affect multiple organs in the early part of the life itself. There is another variant known as late onset Fabry, usually present as isolated cardiac or isolated renal involvement, usually presents during the adulthood. These forms can be milder, but later it can progress also. So usually Fabry's occurs in male child. So there will arise a question that can females be affected due to Fabry's disease? Of course, through a process known as lionization. If the lionization is a process in which the X chromosome, one of the X chromosome get inactivated. Usually females will have XX chromosome, of which one of the X chromosome will get inactivated due to lionization, causing this genetic mutation to have a pathogenic effect in the body. This is a simplified figure showing the pathogenesis of Fabry's disease. Fabry's disease will be characterized by the alpha galactosidase deficiency, leading to substrate accumulation in the lysosome, that is GB3, globotriaoside ceramide, which lead to target organ dysfunctions, can cause vascular occlusion due to endothelial dysfunction and pro-inflammatory pathways, and cause fibrosis, especially in heart and kidneys, and cause neuropathy. So we will see the clinical features. Neurologically, it is one of the most characteristic feature is the small fiber neuropathy. The patient will have burning pain in hands and feet, that is acroparesthesia, early stroke, and TIA, most predominantly posterior circulation stroke. These patients are more prone for posterior circulation stroke, dizziness and tinnitus. Renal involvement will be characterized by proteinuria, which is progressing to CKD, and these patients usually will reach the end-stage renal disease in their 3rd or 5th decade if they are untreated. Then cardiac manifestation include left ventricular hypertrophy, which mimics HCM, conduction abnormalities, arrhythmias, and heart failure with preserved ejection fraction. So coming to dermatologic manifestation, this manifestation is so unique that it makes the diagnosis of Fabry's more easy, because this dermatological manifestation can be visible to the physicians. These patients will have angiokeratoma, especially in the lower part of the trunk. The presence of angiokeratoma in their bathing trunk distribution is one of the telltale signs we have to look for in case of Fabry's. These patients also will have hypohidrosis or anhidrosis. They will have an increased feeling of heat in their body because of the lack of sweating. Ocular manifestation include cornea verticillata, that is wall-like opacities in the cornea, which usually will not affect the vision. And posterior spoke-like lens opacity is also seen in case of Fabry. Gastrointestinal manifestation include postprandial abdominal pain as well as diarrhea, typically due to vasculopathy, and psychiatric symptoms like depression, fatigue, and reduced quality of life also be seen in Fabry disease. So this is the most important part of our talk. When should we think Fabry? So if a young male is coming with an unexplained left ventricular hypertrophy, early onset stroke or TIA, proteinuria or CKD of unclear etiology in a young adult, chronic neuropathic pain in the extremities without diabetes, family history of renal failure or cardiac disease or early strokes in male, systemic symptoms with angiokeratoma or corneal changes. So if the patient is having these symptoms, you should think of Fabry as one of your differential diagnosis. How you can approach or reach this diagnosis or confirm this diagnosis? You can do the enzyme assay, that is alpha galactosidase A activity. In male, this is usually diagnostic. In females, these patients, this enzyme level may be normal because of their heterozygosity or lionization. So they have to proceed with genetic testing. Genetic testing is actually gold standard for both males as well as females. Genetic testing is very important. It is the gold standard for confirmation. Not only confirmation, genetic test has a role in deciding whether which treatment to be given in this patient. Why it is? Because certain mutations, genetic mutation, you can treat with a chaperone therapy, which we will discuss in later. So you can also use biomarkers, that is GB3 levels, lysosomal GB3 levels, to assess the disease activity or disease burden. Look out for the end organ damage, that is organ specific assessment, cardiac MRI, Holter, and echo to assess the cardiac function, renal biopsy if needed. The patient is having proteinuria, then you have to proceed with renal biopsy, neurological evaluation, and skin biopsy if neuropathy is suspected. So coming to the treatment principle, there are two arms in this treatment protocol. One is disease-specific therapy, that is targeting the substrate accumulation. Second is the supportive and organ-specific management. So coming to the disease-specific therapy, most important is the enzyme replacement therapy, that is we are replacing the galsidase, that is a galsidase beta, that's enzyme. This enzyme we are giving 1 mg per kg IV for every 2 weeks. Both alpha and beta we are giving every 2 weeks. Coming to oral chaperone therapy, that is migalastat. We are told that some mutations, then there is enzyme production is normal, but the produced enzyme is unstable. So if you are giving this chaperone therapy, this unstable enzyme will be stabilized. Migalastat is the treatment, chaperone therapy treatment in case of Fabry disease. The use of migalastat is supported by the trials as FACET trial as well as ATTRACT trial, and the emerging therapies include substrate reduction therapy, mRNA therapy, and genetic trials, gene trials are ongoing. So the supportive therapy, as all know, in case of neuropathy we use gabapentin or duloxetine. In renal for proteinuria, ACE inhibitors or ARBs are preferred. In case of cardiac involvement, treatment protocol for cardiac failure with reduced or preserved ejection fraction should be given. We have already told that the trials which supports the treatment of Fabry disease, one is FACET trial, which supports migalastat, and ATTRACT trial demonstrated stabilization of renal function and reduced LV mass in the patients are treated in early stages. And Anderson-Fabry enzyme replacement registry studies found out that long-term benefit if you are using this enzyme replacement therapy in the earliest stage. So how you have to monitor these patients? So these patients should be annually or regularly followed with the yearly echo and ECG, and proteinuria every 3 to 6 months, and lysosomal GB3 level for monitoring the therapy, whether it is the disease burden is improving or not, and Holter. If there is any arrhythmia, you are suspecting an arrhythmia, you have to do a Holter. And family screening is crucial. Suppose the patient is diagnosed with GALA gene mutation, then the whole family should be screened for that mutation. So this is the take-home message from our talk. Think Fabry in unexplained LVH, CKD and acroparesthesias without diabetes, especially in a male. Enzyme assay and genetic test are diagnostic, especially the genetic test. It is both diagnostic and will decide the treatment, which treatment you should proceed with. Enzyme replacement therapy and migalastat can halt and reverse the damage if started early. Family screening is important once the index case is diagnosed. So, thank you. With this, we conclude this session. I hope you have enjoyed.